Hey everyone, Bob Gibson from Rosk here. Welcome to a bonus lesson within the IV Vasoactive module. We're here to discuss Midodrine in the ICU today. When I look around, I feel like we don't have clear guidance or, for that fact, understanding of available literature on the topic. In fact, it seems like the Wild West at times when it comes to Midodrine prescribing practice patterns in the ICU. And for that reason, we're going to spend some time exploring what data there is, understanding if Midodrine is effective in the ICU, and then we're going to try to form some of the best recommendations for our bedside care. Alrighty, let's get started. Briefly, we're going to look at Midodrine's background and history, its proposed utility in the ICU, some fine details of the medication itself, and then an abbreviated literature review. We'll then try to summarize the information we cover so we can make it applicable to your use at the bedside. First, some interesting overall history concerning the drug. In 1965, Midodrine was patented. In the 1970s, around the mid-1970s, late 1970s, Midodrine was described in the medical literature. And then in 1996, the FDA approved the medication for symptomatic orthostatic hypotension. However, in 2010, the FDA actually tried withdrawing the medication because the manufacturer did not produce any post-marketing studies. However, due to healthcare providers and consumer complaints, this recommendation was delayed pending phase 4 trials of the drug. Then finally, in 2016, a phase 4 randomized controlled trial demonstrating a reduction in tilt table syncope was released, and this satisfied the FDA. I think it's kind of funny to think how close we were to not even having this medication in the US at all. Now some history on Midodrine pertaining specifically to ICU care and research. We first started seeing case series exploring Midodrine's use in the ICU in the early 2000s. In 2002, we saw it in spinal surgery. In 2005, we saw it in stunned myocardium, which just saying that out loud makes me shiver. Then in 2008, we saw a case series involving carotid artery stenting. In 2013, we saw one of our first major observational trials, followed by 2 observation trials in 2016. In 2020, we saw our first major randomized controlled trial. This would be the MIDAS trial. And then shortly thereafter, we saw a meta-analysis in 2021. 2022 was a good year for randomized controlled trials. We actually had 3 major RCTs released that year. And even as we speak right now, there's studies in production trying to explore the treatment modality. A bit of background on the medication. The FDA approval for this medication is again for symptomatic orthostatic hypotension. The medication also has numerous off-label uses. This includes cirrhosis, hemodialysis-induced hypotension, hepatorenal syndrome, posterior orthostatic tachycardia syndrome, and vasovagal syncope. The medication does carry a black box warning for supine positional hypertension. The warning also carries with it an interesting statement, quote, "Use in patients whose lives are considerably impaired despite standard clinical care," end quote. So let's clarify what we're here to discuss. The proposed use of Midodrine in the ICU is to facilitate IV vasopressor therapy more expediently. We believe doing so will reduce ICU length of stay, significantly reduce cost, and ultimately allocate ICU beds more efficiently. It's equally important to point out what patients we want to attempt doing this in, and these are patients that are stable, they have resolving shock, they don't display any evidence of hyperperfusion, and they're on only a low-dose vasopressor. We shouldn't be attempting to use this in patients that hypovolemia explains their hypotension, and in addition, we should be hesitant in using this medication in cardiogenic shock patients. Persistent vasoplegic state. So we often see this patient population that their acute shock's resolved, they're warm and peeing, their lactate and end organ perfusion looks good, but they're stuck on a whiff of vasopressor and you can't get the patient out of the ICU. These patients may be in a prolonged vasoplegic state. The state's characterized by a loss of vasomotor tone and persistent low-level systemic vasodilatation causing hypotension. And this could be driven by multiple etiologies, including sepsis, neurological issues, as well as medications and anesthesia. It could be even caused by secondary adrenal insufficiency that was brought on by the patient's previous shock state. Now let's take a look at the drug itself. Midodrine has excellent bioavailability. Midodrine is actually a prodrug, meaning through enzymatic cleavage of its glycine molecule, it becomes an active working metabolite, desglymirrodrine. Desglymirrodrine has alpha-1 receptor agonist properties with no beta activity. Actually, many folks refer to Midodrine as oral phenylephrine. Its alpha-1 properties cause smooth muscle contraction, resulting in vasoconstriction, and as a result, the medication increases SVR and blood pressure. The mean maximum concentration for Midodrine is 20 to 30 minutes, but the active metabolite has a very predictable max concentration of 1 hour. The medication has low protein binding, The active metabolite's elimination half-life is 3 hours, but if the patient is in end-stage renal disease, the elimination half-life can be as long as 10 hours. It's metabolized by multiple tissue types, but the liver is responsible for a large portion. For my PharmD friends, to be more specific, it's metabolized via the cytochrome P450. Even more specific than that, CYP2D6 and CYP1A2. And lastly, disglyminidrin is renally excreted, which is very important to understand. Reviewing adverse effects, first I'll start off with what I feel to be minor adverse effects. And this is pilomotor reaction, so this is piloerection, i.e. goosebumps, and scalp itching, scalp pruritus, nausea, abdominal pain, dysuria, paresthesia, and loss or disruption of taste and smell. On to what I consider the major adverse effects, we have reflex bradycardia, supine hypertension, and urinary retention. The bradycardia is thought to be caused by a baroreceptor-mediated reflex from the increase in SVR. Supine hypertension is self-explanatory. Urinary retention is honestly an adverse effect that I hadn't considered at all, and I can surmise how it might actually increase hospital length of stay when you think about it. This occurs because of alpha-1 bladder receptor agonism, which actually causes increased bladder sphincter and detrusor muscle tone, as well as increasing the urethral closing pressure. Now, up to 80% of patients may experience one of these adverse effects, and the adverse effects appear to be dose-dependent. A daily ICU bed cost is tough to ascertain. A lot goes into this number, and when you get the finance folks involved in the discussion, it gets very confusing, i.e. fixed versus variable cost, gross charge versus total negotiated charges, and so on and so forth. However, I think it's safe to say that a conservative number is between $2,500 and $5,000 per day, and personally, I would be leaning towards the $5,000 end of the spectrum myself. However, the cost of Midodrine is exceedingly cheap. An online search tells us that Midodrine costs less than $1 for a 10 milligram tablet. In fact, my organization's acquisition cost is only 21 cents per tablet. So if Midodrine turns out to be effective in reducing vasoactive use and facilitating quicker ICU discharge, this would equate to a massive cost savings. Now, the big question, is Midodrine effective in speeding up IV vasoactive weaning and moving patients out of the ICU sooner? Well, I had to look to the literature on this, and with that, let's take a look at my PICO questions. The patient population I was looking at was adult patients on low-dose vasopressors. They were stabilized with no signs of hyperperfusion. There was no evidence of hypovolemia and no cardiogenic shock. My intervention was Midodrine enterally for the purpose of weaning IV vasopressors. My comparator or control was standard of care, so this was simply continuing low-dose vasopressors until they were able to be weaned off. And the outcome I was looking for was a median time of stopping vasoactive infusions, the ICU length of stay, hospital length of stay, ICU readmission rates, and adverse effects. I limited my search to the last 10 years, and with that, I came up with 10 articles meeting my search criteria. 3 observational papers, 4 RCTs, 2 meta-analyses, and 1 review paper. The massive amount of content and data here would take a journal club 2 to 3 hours to discuss. With that, I'm going to present these papers in an abbreviated Cliff Note fashion. There's no way I can discuss every detail and limitation, so I urge you to review these papers on your own as well. We'll start off in 2023 with a small paper out of Mass General. It was a prospective observational study that only included 20 adult patients. These patients were stable and only on low-dose vasopressors. They were extubated and showed no signs of hyperperfusion or end organ dysfunction. Important to point out, these patients were observed from a SICU only, a surgical intensive care only. The modal Midodrine use was 20 milligrams every 8 hours. Modal, that refers to the most common dose of Midodrine, so it was 20 milligrams every 8 hours. This was a single-arm trial. There was no control. Essentially, they wanted to look at the rate that vasopressors were weaned before and after the initiation of Midodrine. The pre or baseline assessment was the day before Midodrine was initiated, and the post-assessment was after initiation of Midodrine. And as you can see here, the IV vasopressor wean rate was 0.62 mics a minute every hour without Midodrine, where the IV vasopressor wean rate was 2.2 mics a minute every hour with Midodrine, and this was significant. This resulted in a median time from the Midodrine starting and vasopressor stopping of 17 hours. Now again, this is a single-arm trial, so there's no comparator, and on top of that, I question if the bulk of the patients needed Midodrine at all. Looking at this graph, the mean MAP at the time Midodrine was starting was 76, which makes me think they could have been much more aggressive with weaning the IV vasopressors in the first place. From this paper, we make the hypothesis that Midodrine has the possibility of weaning IV vasopressors faster than standard of care. Moving on to 2016, we have 2 papers to discuss actually. The first out of Wake Forest, North Carolina, published in the Journal of Clinical Pharmacy and Therapeutics. This was a retrospective observational design. They had been using Midodrine for 5 years leading up to this study, thus a 5-year recruitment observation period was utilized. I think it's important to point that out because otherwise you'd be questioning why did it take you 5 years to recruit. Here it was done intentionally. Their practice was to use Midodrine in stable patients on low-dose vasopressors. They recruited out of 2 CV ICUs, 2 medical surgical ICUs, and 1 neurocritical care TICU. They initially had about 1,800 Midodrine patients to screen, but a massive predominance of the population was cardiovascular diagnoses. For that reason, they randomly selected 80 cardiovascular patients to screen out of the 1,500 CV patients they initially had. Ultimately, this brought the sample size to 94 in both the intervention and control group. The Midodrine doses ranged from 2.5 to 10 milligrams, but the modal dose was 10 milligrams every 8 hours. Now, before displaying the results, I'd like to point out that this was an observational paper. The start of Midodrine was at the discretion of the provider. There's clear bias in this study. Midodrine patients were more likely to be on corticosteroids and recovering from multiple vasoactives. In addition, the Apache scores were significantly lower in the Midodrine group. The primary outcome was time to IV vasopressor discontinuation after Midodrine initiation. Midodrine patients discontinued vasopressors at a median of 1.2 days, and that sounds great, but we have no comparator or control. In addition, this is median time overall. When you look at septic patients alone, it almost doubled that at 2.2 days. There was no difference in ICU length of stay or readmission to the ICU, and oddly, hospital length of stay was longer in the Midodrine group. And most interesting, Midodrine patients more frequently required restarting the IV vasopressors. And while a secondary outcome, they reported a significant reduction in mortality in the Midodrine group of 8.5% versus 22.3%, which really doesn't sync up with the rest of the study. I'm not really sure how to interpret this study. At the end of the day, it doesn't do much for me. The other paper from 2016 is the Whitson paper. To me, this is where Midodrine use in this setting started to make way in the literature. It was a retrospective 2-arm observational trial. It included only septic shock patients, 140 patients in the IV vasopressor only arm, and 135 patients in the Midodrine and vasopressor arm. While it wasn't an RCT, the patients were well matched. The patients were on low-dose vasopressors. The mean norepinephrine dose was 0.09 mics per kilo per minute, and the mean phenylephrine dose was 1.05 mics per kilo per minute. I appreciate the fact that the study used weight-based IV vasopressor dosing. It makes it more interpretable from a logistical point of view. The Midodrine dose was started at 10 milligrams every 8 hours and titrated for effect. This equated to a mean Midodrine dose regimen of 18.7 milligrams every 8 hours. The results of this paper were relatively positive. The mean IV vasopressor duration was 3.9 versus 2.9 days, favoring the Midodrine group. IV vasopressors restarted more in the non-Midodrine group. ICU length of stay was less in the Midodrine group. There was a lower change in creatinine in the Midodrine group. And there was only 1 case of bradycardia that required cessation of Midodrine itself. However, we need to be mindful this is a single-center trial, it's observational, there's risk for bias as well as confounding variables that weren't controlled for. Now jumping forward a few years to 2020, we have the Midas trial. It was an RCT and it was blinded. It included 3 tertiary centers in the US and Australia, 2 in Boston and 1 in Australia. However, 64% of the enrollment participants were out of the Australian site, and in addition, about 66% of these patients were post-op surgical patients. These 2 items might limit the generalization of the paper. In addition, it had a very long enrollment period, in which the paper is often criticized for. It had a smaller sample size, but the paper did reach its power analysis to attempt to detect a 6-hour difference in vasopressor discontinuation time. The study's Midodrine dose was 20 milligrams every 8 hours, so this is a higher dose than what we saw in previous studies. To be included in the trial, the patient had to be resuscitated and reversible causes of hypotension treated. In fact, the mean vasopressor doses at the time of enrollment were either phenylephrine 0.52 mics per kilo per minute or norepinephrine at 0.06 mics per kilo per minute. I'd like to highlight a few significant exclusion criteria as well. Exclusions included hypovolemic patients or adrenal shock patients, liver failure, chronic renal failure, a left ventricular ejection fraction less than 30, urinary retention, and bradycardia. Bradycardia defined by a heart rate less than 50. To make a long story short, there were no differences in primary outcome or any of the secondary outcomes, including time to ICU discharge, ICU length of stay, hospital length of stay, and ICU readmission rate. The authors also did some unplanned post-hoc analysis. They looked to see if there were differences in IV vasopressor discontinuation times in patients receiving epidural analgesia. They did this because about 23% of the study participants were on epidurals. They also looked into patients with differing diagnosis, more specifically surgical DRGs for sepsis and other medical diagnoses. Lastly, they looked to see if taking opiates affected the response as well. But the only signal they found was that patients receiving epidural analgesia had a significantly shorter IV vasopressor run. Concerningly, there were more incidents of bradycardia in the Midodrine arm. Bradycardia was defined as a heart rate less than 40 or a decrease in heart rate by greater than 20%. So my criticisms include the study's heterogeneity in conjunction with its small sample size, not using weight-based vasopressor doses, limited recruitment from the USA, and the post hoc analysis not being pre-planned. In addition, the mean MAP again at enrollment was about 75, leaving the question as to why. Why weren't these vasopressors more aggressively weaned? Did the patient even need Midodrine? Unfortunately, overall, this is a negative study. It also showed a signal for possible harm. We do, however, leave with a hypothesis-forming result as to if the patient on epidural analgesia responds better to Midodrine. Now we jump forward a year, and this meta-analysis is published out of Critical Care Research and Praxis. The authors found 9 papers. 3 of those papers were excluded because they were in abstract form and lacked data. That gets the analysis down to 6 papers, 1 RCT, and 5 retrospective observational reviews. We need to be reminded that the meta-analysis is only as good as the studies that are included in them. A more crude way of saying this is shit goes in, shit comes out. In this case, we only have 1 RCT, the other 5 studies are low-level evidence in the form of observational trials. Now, as you know, critiquing meta-analysis is complex and time-consuming, a task best served for Journal Club. With that said, I'm only going to discuss the main results. Now, before displaying those results, I want to point out that IV vasopressor duration wasn't studied in this analysis due to lack of data from the 6 included trials. Let's look at our results. Midodrine use was not associated with a significant reduction in ICU length of stay or hospital length of stay. Midodrine use did not significantly reduce mortality. There was no difference in IV vasopressor reinstitution or ICU readmission, and there was a higher trend of bradycardia in the Midodrine group. And as you can see, there's a huge degree of heterogeneity. In fact, I really don't recall the last time I saw an I-square of 86%. This large degree of variability makes interpreting this data very difficult. A year later, we saw an increase in RCTs exploring Midodrine use as an IV vasopressor weaning agent. This included the 3 RCTs you see here. The first is by Ali and Associates. This was an unblinded RCT hosted in a single-center Egyptian trauma intensive care unit conducted on patients with the specific diagnosis of spinal shock. There were 99 patients eligible for enrollment. With that, 9 declined to participate, leaving 90 participants. There were 3 arms of the trial, a control group, a Midodrine group, and a Midodrine group. Midodrine is an enteral form of desmopressin. The dose of Midodrine was 10 milligrams every 8 hours, and within the intervention groups, an attempt to wean vasopressors commenced once the patient received 4 doses of the study drug. In addition, it seemed as though patients were kept in the ICU for 24 hours after discontinuation of the study drugs, and to me, this explains the overall long ICU length of stay. I found this paper to be somewhat awkward, and we can definitely spend time nitpicking it, but instead, I'd like to share some main points and just a few limitations of the study. Here you can see the primary outcome, the duration of IV vasopressor requirements. In the control arm, we have a mean of 6.93 days. In the Midodrine group, we have a mean of 3.3 days, and in the Midodrine group, we have a mean of 4.8 days, and this is significant. For a secondary outcome, we have ICU length of stay. In the control group, we have a mean of 9.03 days, 5.13 days in the Midodrine group, and 5.5 days in the Midodrine group, and this was significant. This is great and all, but there's major limitations. One thing to point out right away is that the Midodrine group received almost 1,500 mLs more fluid than the control group. This may have affected the results. Next, the study is conducted in a very specific location of the world with a very specific patient population. This obviously limits generalization. In addition, while it's not clearly indicated, it seems to be an unblinded trial. What I do like about the paper is that it addresses a population with a homogeneous neurological cause of hypotension, possibly helping us to understand what populations benefit best from Midodrine. The second RCT from 2022 was a single-centered unblinded RCT out of once again Egypt, this time published in the Irish Journal of Medical Science. They studied Midodrine's utility in weaning norepinephrine during septic shock. These patients were on low-dose norepinephrine. The definition of low dose was less than 8 mics per minute, and they had to be on norepinephrine for at least 24 hours. There was a 60-patient sample size split into 2 arms of 30 patients each. One arm with norepinephrine only, and the other arm with norepinephrine and Midodrine adjunct for weaning. The dose of Midodrine in this paper was 10 milligrams every 8 hours. At first, I thought they had a composite primary outcome, but I was wrong. Rather, they had 3 primary outcomes. This included the median duration of norepinephrine administration, 4 versus 6 days, favoring Midodrine, norepinephrine weaning time of 26 versus 78.5 hours, favoring the Midodrine group, And then lastly, the mean total norepinephrine dose, and they measured this in overall milligrams. It was 102 milligrams versus 175 milligrams, again favoring the Midodrine group. As far as secondary outcomes, we have mortality with the earth-shattering 43.3% versus 73.3%, and this favored the Midodrine group. There was no difference in ICU length of stay, and the Midodrine group demonstrated significant cost savings. Now, looking at the ICU length of stay, both groups had a mean of 12 days, and you have to ask why given the remaining of the positive results. The authors explain this because allegedly they discharged their patients directly home from the ICU, and that's quite the unique practice. We need to make note of that. There's obvious limitations to the paper, including its unblinded, single-center nature. In addition, we continue to get handed non-patient-centric primary outcomes. The mortality benefit once again raises a brow, but this is a secondary outcome and only hypothesis generating. To add to that, 73% mortality rate in the control arm is very high for septic shock, and this carries no explanation within the paper. Moving on to the last RCT in 2022, we have the Maverick trial. And this was an Australian pilot open-labeled RCT. It screened 381 patients, and after exclusion criteria, only enrolled 62 patients. 32 were assigned in the intervention arm with IV vasopressors and Midodrine, and 30 patients were assigned in the IV vasopressor only arm. Inclusion criteria saw patients that were deemed to be clinically stable by the treating clinician. So the clinician had some guidance in this with maximum vasopressors, and this required the patient to be on less than or equal to 10 mics a minute of norepinephrine, or less than equal 100 mics a minute of a non-FDA approved inopressor. The Midodrine dose in this trial was 10 milligrams every 8 hours. The primary outcome was mean time to stopping IV vasopressors, and as you can see, there was no difference. The secondary outcomes were protocol compliance and length of stay. And as you can see there was excellent protocol compliance of almost 97%. There was no difference in ICU length of stay, and there was no difference in hospital length of stay either. Also worth pointing out, there was more bradycardia defined by a heart rate less than 50 in the Midodrine group, but there was no incidence of a heart rate less than 40. In fact, the authors go on to explain that there was only one episode of bradycardia that was deemed clinically significant. Now, the Maverick trial did utilize a Midodrine weaning protocol, which I feel is a positive of the trial. At the very least, it gives us some framework when caring for our patients at the bedside. There's a handful of worthwhile critiques to mention. It's obviously an open-label trial. It has a low sample size that was only recruited out of 2 hospitals in Australia. Again, the mean MAPs were between 72 and 75 at baseline, questioning the aggressiveness of the IV vasopressor weaning. And my biggest gripe of the paper is that they excluded any patient with AKI. They defined AKI as a stage 1 KDIGO or greater staging level, and in my eyes, this really limits the results. In fact, exclusions were significant with AKI, heart failure, liver failure, and bradycardia accounting up to 44% of the excluded patients in the trial. Now we move on to our last paper, a meta-analysis released in 2023 out of Cardiology and Therapy. The paper's final analysis included 4 RCTs, and please make note that these are the 4 RCTs that we've already briefly reviewed. The meta-analysis had a total of 314 patients when all was said and done, 154 in the Midodrine and IV vasopressor group, and 156 in the control group with just IV vasopressors. As far as the primary outcome, there was no difference in total time of IV vasopressors. Unfortunately, there was no benefit seen in the secondary outcomes either. There was no difference in time to IV vasopressor discontinuation, no difference in IV vasopressor restart rates, no difference in ICU length of stay, no difference in hospital length of stay. Now, unfortunately, there was an excess in bradycardia seen in the Midodrine group. Now, the risk of bradycardia is what really hangs me up and where I'm at personally at Midodrine use, so I decided to dig a bit further. The meta-analysis uses the Midas trial and the Maverick trial to assess for bradycardia, and the Midas trial was cut and dry. There was more significant bradycardia, and maybe this was because of the higher dose of Midodrine. Now, the meta-analysis assigns 80% weight to the Maverick trial to understand the risk of bradycardia. Exploring the Maverick trial a bit more in regard to the bradycardia, the authors note that there was only one clinically significant bout of bradycardia. However, they define bradycardia as a heart rate less than 50. Now, it appears once they determined that they had a 31% bradycardia incident rate using the cutoff rate of a heart rate of 50, they then dropped the metric to heart rate less than 40, leaving them saying there was no severe bradycardia. The mean starting heart rate in the Maverick trial was about 76. So a medication that unintentionally drops a heart rate by about 30 beats per minute is significant, at least in my eyes. I'll make a quick comment that with the exception of hospital length of stay and bradycardia, the remaining outcomes had a large degree of heterogeneity seen throughout the studies. Once again, this makes interpreting data very difficult. All right, that was a lot of data given to you very fast, so let's do a quick summary. Our 2013 observational trial gave us relatively positive results. Our 2016 observational trial left me kind of shaking my head. The 2016 observation trial gave us positive results as well. In 2020, we get into the Midas trial, a blinded RCT, and this gives us negative results. And to no surprise, the meta-analysis a year later is once again negative results. Our 2022 unblinded RCTs give us varying results, a positive, and a negative. And then lastly, our 2023 meta-analysis gives us overall negative results. So now let's put together some thoughts or comments. I find myself thinking as the quality of evidence increases, unfortunately, I start to see more negative results. Just a thought to leave you with there. It's once again important to be redundant in saying these are stable patients with resolved shock in a low-grade vasoplegic state requiring minimal vasopressor doses. The duration of action is worth mentioning here. In a patient with normal performing kidneys, the duration of action is 3 hours. However, we dose the medication every 8 hours. This just doesn't make sense to me. As far as dose, some folks, including me, fear that the 10 milligrams of Midodrine isn't enough. It also seems that as you go up on the dose, as seen in the Midas trial, you get dose-dependent side effects, most concerningly bradycardia. So there seems to be a narrow therapeutic window. And then also the absorption. These are folks in resolving shock and their gut motility may be affected due to multiple culprits. It makes me wonder if this is part of the problem in understanding if Midodrine is effective. We also have to worry about differing etiologies of vasoplegia. Just in these reviewed studies, you saw sepsis, surgical, neuro, and epidural analgesia related to vasoplegia. Cellularly, these pathologies are different. It begs a discussion as to possible variability in Midodrine's effectiveness. Also, the studied IV vasopressors are different. So if we exclude the non-FDA, non-US inopressor and just look at the other two vasoactives we see in these papers, you have phenylephrine and norepinephrine. Norepinephrine is a more potent vasoconstrictor than phenylephrine. So would this explain some variation in results, i.e. a patient on phenylephrine might respond to Midodrine better since phenylephrine is weaker, thus the patient intrinsically needs less support. I also hate the fact that there's a lack of weight-based dosing. While some of these papers declared the mean weight-based dose of these vasoactives in the back end of the results, the front end of these papers, the inclusion criteria, use non-weight-based dosing of vasopressors in all except one paper. So there's a difference between 10 mics a minute of norepinephrine in a 50 kilo patient compared to a 100 kilo patient. And it really makes me think of this as affects some of the results. Unfortunately, given the current level of data that we possess, it remains unclear if Midodrine is effective in weaning off IV vasopressors. Unfortunately, with the paucity of literature also comes a signal for possible harm. The clearest adverse effect would be bradycardia. And what about a taper protocol? I feel like if we're going to do this, we need to have some standardization on the starting dose, but also the weaning dose. And the Maverick trial gave us some working construct to this tapering protocol. And lastly, what happens to these patients once they travel out the doors of the ICU? Does the hospitalist know to wean the medication? Is there a knowledge deficit concerning the indication for the medication? Does it just get lost in the shuffle? What happens if the patients inadvertently get sent home on Midodrine? Well, I have a paper to quickly present to shed some concern on the topic. A retrospective observational paper out of the Mayo Clinic. This paper shared with us some concerning stats. I think we all can agree that the Mayo Clinic folks are no slackers. They provide some of the best care in the world. They looked at patients admitted in the ICU with a newly written prescription for Midodrine for the purpose of treating hypotension in the ICU. 67% of the patients continued Midodrine at the ICU transfer. That's not overly all surprising. However, a third of those patients continued Midodrine at the hospital discharge. That means they left the hospital on Midodrine. And what's even more concerning, 50% of those patients were discharged with a concurrent antihypertensive prescription. This paper lets us clearly understand that we have to be educated about the treatment modality. Our hospitalist colleagues need to be educated, and our pharmacy colleagues need to provide oversight in the management of this medication. Now, what about the future of Midodrine? So what's next for Midodrine research? Well, we have a Canadian blinded, multi-centered RCT, the Liberate trial. It started recruiting in March 2021. They're aiming for 350 patients with 175 patients in each arm. They're comparing 10 milligrams of Midodrine every 8 hours versus control. The primary outcome will be ICU length of stay, with 5 secondary outcomes and 5 health economic outcomes. We also have another meta-analysis underway from the British Medical Journal. There's limited information on this review, but it appears as though that we'll be doing pre-planned subgroups in an attempt to find the ideal patient population for Midodrine. So we'll have to keep our eyes open for these upcoming papers. In the meantime, let's try to put together some sense of all the data we discussed. As you can see from the evidence I presented, nobody knows the answer, as of yet. We all want this to work. It could result in a massive cost savings, and it could also free up beds in the ICU. We absolutely need to remember that this discussion applies to patients that are clinically stable with no signs of hyperperfusion and is only on low-dose IV vasopressors. If we choose to use Midodrine in this proposed fashion, we need to have some standardization in dose, recognizing factors like kidney injuries. We should also have a standardized tapering regimen. In the same breath, we need to be mindful of adverse effects. My biggest concern being bradycardia. We want to be cognizant of bradycardia possibly occurring, and we definitely don't want to start Midodrine in an already bradycardic patient. We need multidisciplinary, system-wide education of the treatment modality. We need to stop flying by the seat of our pants on this matter. We should also clearly discuss the treatment and our recommendations in weaning Midodrine in our ICU transfer summaries. And then lastly, it also seems clear we need our clinical PharmD's oversight in initiating, weaning, and watching for interactions and contraindications. Now, the EMR should also be able to provide some safety stops here as well. It should fire an alert when a provider places an order for an antihypertensive when the patient is concurrently on Midodrine. Well, that concludes this quick rundown on Midodrine in the ICU. I've ran through this data at a very fast rate. I would suggest that you review the literature yourself, and you can find all the articles mentioned in this bonus lesson in the resource section of the LMS page itself. You have downloadable PDF access to these articles. I hope you found this review valuable. Please send me your comments or questions in the comment section below. I appreciate your attendance, and until next time, take care. Thank you.